Right. Shall we? Kathleen, are you muted?
Yep, I'm ready now. Sorry.
You want to?
All right. Good morning, everyone. Thanks very much for joining our third Equitable Care webinar of the year. Wanted to welcome everyone here on behalf of the YCAP Equitable Care Committee. For those of you whom I haven't met, my name is Kathleen Kieran. I'm one of the co-chairs of the committee along with Peter Asante. We are here today with two guests to talk about the medical record and how to leverage that for healthcare equity. So I'm going to start off with a brief introduction, and then we'll move on to introducing our speakers, and then we'll move on to the webinar. So I wanted to, you can go to the next slide, Alexis. I want to introduce you to the committee. These are the people who do all the work. This is from our retreat, which was back in, I believe it was in May. It seems like so long ago. But these are the people who put together your toolkit, which is currently being revised. And we're really lucky to have people who represent diverse backgrounds and diverse experiences throughout Washington State. So when you look at the toolkit that's online, please recognize that these are the people who put it together. The background of the toolkit is that in 2020, the U.S., as you know, had a national reckoning about race and the role of race in many aspects of life, all aspects of life, in fact, but particularly with healthcare. We put together this work group to help promote and establish a group that would support clinics and those who care for children to provide equitable care, make healthcare more welcoming and responsive to families of color, and delivering high quality care to diverse patients and families in Washington State. So the link is here. Alexis, usually you put it in the chat, so if you could throw it in the chat, that would be great. And it is currently being updated, so we will have some a new section and some updated material. These are the initial contributors. You can see that most of these people have stayed on, but some of them have transitioned, and the prior 4 sections are listed here as well. So we really thank these people. That was a huge lift. As I mentioned, we're revising the toolkit. The toolkit's available online, has been utilized by over 200 clinics throughout Washington and throughout the country. Our goal, as I mentioned, is to remain timely, ensure we're providing accurate and relevant resources that are up to date and are actionable for every group. And so we hope to have this done by the end of 2023, but I'll be honest, this group really gets things done, so we will get it done by the end of 2023.
Right.
Without further ado, I'll turn it over.
Hi, good morning, everyone. I'm Dr. Peter Asante, and I have the privilege of introducing our friends and colleagues, Dr. Grigg and Dr. Clara Lin, who will be talking about electronic health record design equity. We'll do some intros. So Dr. Grigg is a general pediatrician trained at Seattle Children's Hospital and also board certified in clinical informatics through ABPM. After residency, he worked at a community health center for over a decade in Toppenish, Washington, during which he became an Epic physician builder and physician champion during the clinic's conversion to Epic EMR. This experience motivated him to gain board certification in informatics as a way to affect the care of patients beyond his panel and to help advocate for better efficiencies within the EMR for his colleagues. Outside of work, he enjoys spending time with his children and his 2 dogs, as well as camping, hiking, fishing, hunting, cooking, and 3D printing. And he currently works as CMIO at Grande Ronde Hospital and Clinics in Oregon. Dr. Clara Lin is CMIO and Associate Vice President for Seattle Children's Hospital. She's a board certified physician in general pediatrics and internal medicine. She's a practicing general pediatrician at Seattle Children's Odessa Brown Children's Clinic in Othello. And she also is the Chief Medical Information Officer at Seattle Children's. In her current position, she strives to innovate and optimize the use of health IT with a focus on advancing the quality and safety of the care delivered to patients and families, improving clinician well-being, and prioritizing healthcare equity. And with that, I'll turn it over to the 2 of you. Good morning.
Good morning. Okay, Erin, I will kick us off if that's okay.
And I apologize if I look like I'm looking away. It's because I have two screens set up and the other screen is really far away from me. So next slide, please. All right, so sorry, we have no disclosures here, and my name is Clara, as you all know, and thank you, Dr. Asante, for the wonderful, lovely bio and introduction. Thank you. All right, so today, Dr. Grigg and I are going to talk a little bit about electronic health record and how it's contributing to health inequities for patients and for providers, and how we can leverage the power of technology to address these inequities that are created by technology itself. We're going to touch on some of the efforts that Dr. Grigg and I are actively working on in our organizations also. All right, next slide. Great. So as the field of medicine and technology continue to evolve sort of separately, we're also starting to see an increasing reliance on technology in the healthcare in general. The HITECH Act is really kind of what kickstarted all of this. The Health Information Technology for Economic and Clinical Health, always takes me a while to get that verbalized. The HITECH Act was signed into law in 2009 to encourage the use of an electronic health record for all of the care that we're delivering. In the earlier part of the last decades of the 2010s, most of our organizations are scrambling to get on some kind of an EHR system in order to meet the government's definition of meaningful use, to receive incentive payments, and also to avoid penalty. So that's where you see kind of a boom of this EHR started to happen. Epic is just one of dozens of EHR softwares out there, but it is the most commonly used one among the larger hospitals here in Washington State. Epic, along with most of other EHRs, are developing their patient portal for the better part of early 2000s. And Epic released their version of it called MyChart in the year 2000. Other softwares have their own. And this portal for patient to access their own information, completing tasks like paying your bills or requesting for appointment, is really what transforms what we used to call electronic medical record into what we now call electronic health record, or the EHR. This rapid development of MyChart and patient portal in general over the last 2 decades has really increased our dependence on technology to help extend the care to our patients in their homes between clinic appointments. And then 2 years ago, in 2021, the ONC passed the final rule of 21st Century Cures Act that requires organizations to provide patient access to their information electronically at no cost, and healthcare providers are no longer allowed to block information from being released immediately to our patients, except for very specific scenarios and exceptions. And then finally, this is the most recent one, health IT recommendation from the government is something called TEFCA. And TEFCA aims to establish an infrastructure where organizations are currently recommended, but in the future will be required to share clinical information with each other beyond their own vendors. So Epic can talk right now, but in the future, they're going to make Epic and Cerner and Epic and other types of software talk so we can share information about the same patient countrywide. So as you can see, we started out, 2 decades ago, requiring all provider organizations to be on some sort of a computer technology electronic record, to now we're requiring information to be shared immediately with our patients on the portal and with other providers on the TEFCA network. So the idea here from the government is to leverage the power of technology to deliver the best of care and to eliminate gaps in care. Because, we all have technology, and once we get on the same technology platform, that supposedly levels the playing field. But does it actually level the playing field is the question. So next slide. Next slide, please. Thank you. All right. The underlying assumption here is that our government and even our vendor like Epic is making is that as long as you have access to that technology, you're getting on the same platform, then you're starting off on the same foot as the person sitting next to you who has the same app on their phone. But is that really the case? Or in Dr. Asante's word, is Epic the new TikTok? And so that's the ongoing debate and frequently studied in literature. So in a recent article, it was demonstrated that about 20 million or more individuals in this country do not have broadband access. And the majority of these patients come from an underserved background or live in rural areas. And although 81% of our individuals who have smartphones, majority of our racial and ethnic minorities who have smartphone rely solely on that phone for their internet access. So broadband access, like many other things, are invisible barriers for our patients and our families to get on this playing field that the government and Epic has, idealized the vision. And beyond getting online and accessing that app, there's so many other more invisible barriers. So like language and health literacy being some of the most daunting challenges for some of our patients. Health literacy, specifically digital health literacy, is lacking across this country. A study recently showed that after controlling for access to internet and to technology in an adjusted analysis, patients with limited health literacy had a higher odd of never signing onto their portal compared to those who don't report any health literacy limitations. And so, there's a whole lot of things that are really creating that gap. And I'm going to pass it on to Dr. Grigg to describe what that gap looks like.
Thank you, Clara, and thank you, Peter, for that wonderful introduction. So what I wanted to do first was kind of jump back a little bit and talk about what is equity. What is it really? We have to have a definition in order to say, is the EHR affecting, or how is it affecting the equity for our patients, for our providers? And so looking back at this publication by the Institute of Medicine, Crossing the Quality Chasm, they define equity as to continually reduce the burden of illness, injury, and disability, and to improve the health and functioning of people in the United States. In particular, the quality of care should not differ because of such characteristics as gender, race, age, ethnicity, income, education, disability, sexual orientation, or location of residence. And just kind of going back to your comment there, Clara, about having access even to internet. When I was living in the Yakima area, I did not have access to broadband more than 30 megabits per second. And most of the people around me didn't have the ability even to get that in their homes. And so there are definite inequities in rural communities as far as access even to broadband. But you're right, many of my patients had smartphones, and that was their access to the internet. So next slide. I was looking at the literature out there, and I came across this systemic review of looking at those specific domains by the Institute of Medicine. So they looked at different domains of quality, including effectiveness, patient-centeredness, safety, efficiency, timeliness, and equity. And these, they went through and surveyed over 6,000 articles that they screened, and ultimately only included 23 after their full text review. When they looked at those domains, there were 0 articles looking at timeliness and equity. And so this remains an area within the research that really has been untapped as far as looking at equity. They did make the point that uptake of portals may differ by patient-specific factors, with lower use by racial and ethnic minorities, patients with lower education level or literacy, thus leading to this digital-led inequity. Next slide. So then, for our first portion here, talking more about those patient inequities and what may drive those patient inequities. So we have this digital divide, as we might say, those who can and those who can't access that information electronically. It affects that patient involvement. I think there are some patients that feel more distanced because they don't have that same access as others. It affects their engagement. It may affect engagement for good. And when we think about the new generation that's coming up, they have more access to things. They don't have to go to a library to access information about their health if they have access to their portal. And so we see this difference between, and I think us in pediatrics, we tend to see many of our patients being able to access that when we think about the teens that didn't have access before, but then we have others that have the low literacy, don't have access, and then don't have the ability to look into those same resources as others. One of the articles that I looked at entitled Ethical Issues and the Electronic Health Record, they said that ironically, patients who might benefit most from digital access may be least likely to have it. And therefore the EHR may just exacerbate the digital divide between those with and without internet access, contributing to health disparities. When I came out of residency, an untold number of years ago, but I was very interested in health literacy and looking at how patients accessed care, thought about their care. But at that time, it was much more about how to understand the health system, how to understand what your condition. But over the last decade, I have seen it grow to be much more inclusive of that digital aspect. How do I access my care team? How does my care team communicate me? How do I interpret these labs that I'm now getting before my provider has a chance to even talk to me? And so I think that those are some of the factors we have to consider when we think about how that may or may not affect the equity for any particular patient. Access to care teams and communication to our care team. So scheduling, the ability for patients to schedule online, the ability for them to access telehealth. This, because some don't have access, that may be a barrier to them, but for others in rural communities that may not have had access to specialties at Seattle Children's or other hospitals, they can now have that access within their community without needing to drive. So it kind of goes on both ends of that equity spectrum. Cell phone service we've talked about, and broadband service as well. Patient language is another one to bring up because the majority of the information coming out on EHRs is in English, and it's still in the development to be getting other languages beyond. So I see a lot that are in Spanish, but even in the Spanish translations, not everything is translated, and so those patients can run into barriers. Confidentiality is another aspect to consider. And so when you think about putting your information out there, is it going to be a barrier to some patients who may not want their information to live in that electronic space, and so they're less likely to put that information on? Or in the clinic I'm working in right now, we have tablets we will give to the teenagers, and so they're able to give their confidential answers without that being recorded on paper that a parent might look at. So it can go both ways in either helping or decreasing the trust and the confidentiality of our patients. And finally, I just wanted to touch on bias. And so bias can come in many ways, one of which can be bias in the way of omission. So thinking about if a patient is not asked about their social determinants of health, we may not know going forward that they don't have access to transportation or safe housing. And so those biases will definitely help us to or will impede the care that we have for those patients. And then thinking about those biases of commission, where how we write about a patient as a provider in the EHR affects the next care team. As they read what we've written, we may inadvertently give some of our biases off to that next team. And so making sure that we are writing things in a way that are equitable for those patients so the next care team can take care of them. Next slide, and I'll pass it back to you, Clara.
Thank you. So here I really wanted to just demonstrate some real world data that I gathered from our Seattle Children's database just last week. So in our own patient population, about 65% of the total patient population identifies English as their preferred language of care. However, this group, which makes up 65% of our patient population, disproportionately makes up a much larger percentage of patients who actually have an activated MyChart account, so at 92%. And this is also the same group that has successfully completed a video visit. So 92% of all of those that completed a video visit are those that identifies English as their preferred language, when that patient population, again, only represents 65% of our population. So this really really shows that English speaking patients have an easier access to technology, at least at Seattle Children's, which is why we, at least organizationally, have made helping patients whose language of care is other than English up to MyChart this year, one of our organizational goals. All right, next slide. Aside from sort of access to technology, I also want to give a shout out to our teenagers, if there are any on the call, or families of teenagers, or those that take care of teenagers. I see Dr. Sednis, Dr. Evans, and Dr. Khan on the call here, who are working tirelessly to improve the care of our adolescent patients. I'm sure there are lots of other adolescent providers and caretakers on the call. So it's really important not to forget this group, that the teen who seems so tech savvy actually faces one of the largest barriers in health technology, and I'm referring to their confidentiality. So as a primary care doctor, I can confidently tell you that when you ask a teenager if they want to sign up for MyChart or sign up for patient portal access and all the awesome stuff that comes with it, you're going to be met with either some indifference, just okay, or general skepticism of whether that actually works. So whether it's for a teen or a provider like myself, it's really hard to trust that the patient portal will help you safeguard a child's right to confidentiality. For one, state laws vary greatly from state to state. So my colleagues in Texas have to configure their portal setup very differently from how we do it here in Seattle, simply because of what the state of Texas allows teens to have privacy is very different from what Washington state allows. The electronic health records software also don't make it super easy for providers to understand what's hidden and what's shared. And so Dr. Evans and I and many others are currently actively working on at Seattle Children's in making that more transparent and more easily usable for our teens and for their proxies. And then finally, a multi-center study that was done at Stanford Children's, Colorado Children's, and Hopkins showed that majority of our teenager portal, their portal account, was accessed at least one time by their guardians or proxies. So about 64 to 74% of our teenagers' accounts are accessed by their adult. So between all of these uncertainties, it's pretty easy to imagine that the clinician and the teams are going to start to lose trust in the portal use for this age group. And therefore, we see probably the lowest percentage of MyChart activation from our patients in this particular age group. Next slide. And this is back to Dr. Grigg.
So the next section we're going to go through is more provider inequities in the EHR. And I don't want this to be a woe is me as a provider type discussion, but we think about our providers and the workload that is put on them. And the heavier and more complex that workload, the more challenging it is to take care of medicine, which is why most of us came in to medicine, is to take care of the patients. And so we think about the EHR and how complex it has become. Those of us that use Epic know that it is a huge number of buttons in front of you, and the complexity of knowing where to go within the EHR to find the information that we need in order to take care of patients can be daunting at times. And combine that with the fact that over the past decade, we've had a huge increase in patients getting onto a portal. Some studies have said that 38% of patients are on a portal, and that's compared to really over the last decade, before we even started down this road a decade ago, very, very few had access to that. And so we now have not only patients and patient care coming in to our clinic and in visits with us, but we now have that care happening asynchronously in the background within the EHR with questions coming to us through that in-basket. So one of the quotes that I liked from this paper, The Ethical Issues in Electronic Health Record, it says, "The complexity of routine primary care visits today and the tasks to be accomplished has increased, but the visit time has not. Managing today's volume of electronic information in primary care with yesterday's staffing ratios is challenging. A clinically focused patient-centered EHR with reduced administrative requirements could facilitate care and help minimize burnout. Addressing this issue is imperative as the care of patients also requires the attention to the care of clinicians. Physicians may feel that their professional integrity is challenged when they cannot provide the care they were trained to provide." And so then we think about different characteristics of providers. And I think as we look at our practices, we may see these types of providers. Some providers take onto computers very easily. They can jump into a new workflow and easily accomplish it, whereas others may take a little bit more time, a little more assistance from those around them. Depending on your organization, you have more access or less access to optimization and efficiency resources. Depending on your practice, you may have more or fewer patients who are accessing the patient portal. And then thinking about charting time and the number of patients within the portal. So we have the percentage of your patients that may be using the portal, the amount of in-basket messages that you're receiving. So how high functioning is the care team for that provider? And so there are some care teams that I've seen where every message gets forwarded onto the provider, others where that care team really takes on that role of helping the provider and getting information so that when that in-basket message goes to them, they're making a decision rather than asking for more information. How much time does a provider spend after hours charting? Or what inefficiencies are built into that EHR given that most of those were not built initially for the care of patients. They were built to help with the billing aspect of things and to run reports and get information out of the EHR. I already touched on the staff contributions, but staffing models and being able to room patients. Rooming patients takes a little bit longer when you're doing it and typing that information into the EHR. And ultimately, I think all of us have seen this, but the quality measures that are dictated to us through different regulatory bodies, how those are put in and where they need to be put into the EHR adds to that complexity. So all of this adds to the potential inequities depending on the provider and the complexity of care, which can then be passed on to the patient because they may not be able to have the full attention of their provider during that visit. Next slide.
All right. Actually, to touch on the provider tech savviness, it's really interesting. I worked at UCLA for many years before joining Seattle Children's in 2022. And one of the clinics that I helped staff went on Epic or any electronic health record for the first time about 8 years ago. And the moment that happened, some of our older attendings in that clinic were saying this is the moment that they will retire because we were forcing essentially their hand to become tech savvy overnight. And so that was really tough for them. And, you know, aside from all the things that Dr. Grigg mentioned, really, I wanted here to demonstrate that the experience and the burnout and the inequities of a provider in the EHR can vary really greatly just by who you are and your demographic as a provider. These studies that I've listed here are all sort of trying to show that. So most of these studies were published in 2022, which is something that I realized when I was putting this slide together. And I think that really reflected a post-pandemic reality where most of our healthcare organizations across the country experienced an exponential rise in the number of patient portal messages that we were receiving thanks to the pandemic. And so we're seeing a lot more burnout with in-basket messages specifically. And so all these studies were kind of done surrounding that context. And so the first study by Dr. Baxter showed that providers identifying as Hispanic or Latino, as well as providers identifying as female, experience significantly increased odds of burnout as related to EHR use. The subsequent studies that I show there, women physicians are also found to spend more time in the EHR both during and after their usual work hours. And women physicians are also shown to spend as much as 217% more time than their male counterparts in handling in-basket messages and receive about 25% more messages than male physicians. And it's really not just a sheer volume of messages that female providers are receiving. The nature and the content of these messages also can differ greatly just because of who you are as a provider. So as an example, a study found that women physicians, as well as those that have a DO degree and those that are primary care doctor, are more likely to be addressed by their first name by the patient, whereas a male MD that are maybe potentially specialists are more likely to be addressed by Dr. So-and-so. All right, next slide. So now we've gone through sort of the inequities that the EHR and the technology gap that the EHR can create both for our patients and providers. We want to show that all is not lost. They can create that equity divide, but we can also leverage technology to benefit our patients, to benefit our providers, and to use it to reduce health disparity. And that really is a mission for CMIOs like myself and Dr. Grigg, and why we like our day job to help improve our lives and to close that gap. So we collect millions of pieces of data in our EHR every single day. And it's our job, like CMIOs, to use them and to use them to our benefit. We can use data to first identify these gaps and inequities, and then take proactive efforts to address them. So at Seattle Children's, there are many things that we have done over the years to try and close that gap. And we're currently doing this every single day also. For example, one of our anesthesiologists, Dr. Dan Lowe, used the data available from our EHR in a tool called AdaptX to identify that there is indeed a difference between in the medical complication rates experienced by patients with different race and ethnicities. But once he's identified that gap, their team really worked hard to develop several strategies to eliminate those inequities. For example, they developed a post-op patient handout using language-independent diagrams. So really it's just a picture, a handout that is mostly consisting of pictures that showed a hydration chart, for example, on how many cups of water recovering patients should be drinking every single day post-op. Another anesthesiologist at Seattle Children's also used data to identify that African-American patients at the hospital had higher instances of post-operative nausea and vomiting. And once this was identified, he instituted a policy and a standard that required for all patients to receive 2 post-operative anti-nausea medication. And over time, he was able to close that gap and demonstrate that this inequity was effectively closed by standardizing the care that we're giving to all patients across the board. And of course, what's a cool technology talk without mentioning the letters AI? AI is a double-edged sword, like health technology in general when it comes to equity. It's a really powerful tool that we can use to our benefit to eliminate healthcare disparity, but we have to do it super thoughtfully. And that's a whole nother hour-long talk in and of itself that I will spare you on, but I'm happy to engage in that conversation if you're interested offline. Next slide for Dr. Grigg.
So in thinking about other opportunities, so one of the big ones that I really take on for myself is to get my teens and my patients onto my chart so that they have that access, encourage them to use it. And while that may not feel like it's the job of a provider to do, they definitely listen to us. And the studies have shown that the more that the provider promotes that portal use, the more likely the patient is to get on and communicate with you that way. Also advocating for language support wherever we can. This is our job as CMIOs, is to really advocate with the EHR companies to make sure that we have that support for our patients, to ensure that they have access to the portal. And this goes back to that idea of what is allowed state by state, making sure that our teens have the access that they need, our parents have access that they need, but that the teens are able to trust us that the confidentiality barrier is still there. Also looking for alternate means for electronic workflows. And as we thought about this, as we move more digitally, are we leading to inequities for those patients that don't have the access digitally? Or in other words, when a parent that doesn't have access to broadband or online scheduling calls at 7:30 in the morning to our front desk, are they met with, oh, all of those appointments have been booked online by people who have that access? So we have to be careful that we are not, as we move into this more digital age, that we're not leaving others that don't have that behind. And then reducing bias. So making sure that, and we'll have a link to a mindfulness toolkit or a mindful language toolkit that allows to reduce that bias in the EHR based on our documentation so that we are not tainting those future generations that are reading our notes about patients, or the next care team that reads our notes in their care. Next slide. So some of the current projects that we're working on here at my organization at Grande Ronde is specifically consistent care team responses so that across different venues within our organization, patients can be met with the exact same expectations of their care team, utilizing the care team so that they know that they don't have to just ask the provider, but that some of the information can be answered by the other staff, the nurses and MAs. We're also instituting refill and lab protocols so that that information doesn't have to reach the bottleneck of getting to the provider, and so that patients can, or that staff can be empowered to serve the patient. And then decreasing note bloat. So we're trying to help providers and staff to write more efficient notes, not only so it takes less time to write them, but because it takes them less time to review when we're going back through and looking at that information.
Yeah, and at Children's, we're the orange text here. We have a couple of projects, or actually many of our projects are really trying to advance our work in anti-racism and health equity. Some of these I've listed here. So patient instruction translation. So we've recently wrapped up a project that translated some of the most commonly used dot phrases or texts that our providers commonly use in patient instructions into the top languages that our Seattle Children's patients use. We also have a different program, a separate program called Device Loaner Program. So for those patients that don't have access to an iPad or a smart device, but needed to complete, say, questionnaires prior to an appointment or post-op care follow-up, we will loan that device to the patient, and there's a whole device loaner program at Seattle Children's. I mentioned earlier, Dr. Evans, Dr. Sethness, and Dr. Khan and I at Seattle Children's are also actively working on the Adolescent Confidentiality Project, looking at the various ways that we can make the electronic health portal for our teens and their proxies a lot more usable while protecting our adolescents' confidentiality to the best of our abilities, but also improving the sign up process and making sure that that is done correctly for our patients. And then lastly, I mentioned also earlier that 92% of our patients who have successfully logged on and completed a video visit were those that identify English as their preferred language of care. And so what Seattle Children's is currently piloting is something called the telehealth navigator. So we're looking at those that have signed up for a video visit, but could potentially have a lot of trouble getting onto that video visit, say because of language or access. And we are deploying a staff member who is a navigator in this navigator role to outreach to this patient ahead of time, help them set up for video visits, help them get online and sign up and sign on. And to hopefully promote a more successful telehealth experience for this population. All right, and last slide, or next slide, is some of the resources that Dr. Grigg and I put together. I put some Seattle Children's specific links there if you want to share this with your patients. So device loaner program, our Spanish services, and also the MyChart and Seattle Children's app available, instructions and information available in Spanish in those links. But really, really importantly is this mindfulness language kit. So Dr. Grigg, I'll let you describe this QR code. You're on mute.
Somehow I hit the pen in the bottom instead of the mic. So this is something you can find on PubMed, or you can just go to the QR code. The QR code will actually direct you to a link to download the Mindful Toolkit. So if you put it on your phone right now, it'll actually just download that kit. But if you copy that and bring it up on your browser on your computer, you can download that full toolkit, including slides and educational materials. I thought it was a really, really good kit to download. So.
Great.
And with that, next slide. All right. So with that, thank you for listening and for joining this webinar. We'll open up for questions that you might have for us.
Thank you guys so much. I can always count on CMIOs to be the most efficient presenters of the bunch. So even with starting late, which we really apologize for. So we've already got a couple of questions that are coming through. So we'll just jump right in. Dr. Lung's question: does a provider's encouraging patients to access online charts disengage patients who have limited access to broadband or data minutes on their phones? How do you assess access before encouraging patients sign up for online charts? And does electronic access need to be included in questions about SDOH?
So I could take that one. I don't know that we have any data about whether a provider encouraging a patient who doesn't have access might disengage them. I think we do have to be mindful, though, of how do we still have that access? And when patients are calling in, that we are taking those and transcribing them in the EHR and still taking care of their concerns, even though they may not have an electronic means for doing so. As we get more and more used to it, I think that will be a concern. As far as access and SDOH questions, and that's an interesting question. The broadband has not typically been an SDOH question that's been asked, but I do feel like it does affect the care that they get. And so that could be included as an SDOH question in the future.
Yeah, I think that's a great idea that we should pitch to Epic and the vendors to include that in the SDOH.
Yeah. That is a great idea. I was like, I never thought of that. How actually can Dr. Lin, can you talk about how does the SCH, the Seattle Children's Device Loaner Program work if patients don't have broadband access at home?
Yeah, that's a really good question, and I'll have to look this up. I don't believe that the loaner devices that we're sending patients home with come with cell phone plans. In other words, you don't need a Wi-Fi at home. I don't know that for sure, so I'll double check on that. But you're right. It again goes back to, we can give you a device, but if you don't have broadband access, you still can't get online, right? You still can't access the technology. So there's still so much that we have to work on. But that is another thank you for recommendation for us to look into, is whether we can enable the cell phone plans for these loaner devices. I mean, just from a very practical standpoint, we also, from the device loaner program, accept a certain level of number of devices that just don't come back to us. And so I guess the question is, how do we manage these cell phone plans then if we have devices that are floating out there? So more for us to think through. Thank you though for the idea.
This question came through from Dr. Martinez, and I'm going to show my naivete for a moment because I don't know if I fully understand it. So Dr. Martinez, if I have you on mute, that's why. Any resources to help with equitable chart entries is the question.
So I think this gets more back to the anti-bias workshop that I was, the mindful language. I'm hoping that's kind of the question, but getting to that idea of how we write about the patients within the EHR, how does that then affect the team? I'm guessing that's, if not, please rephrase that question to help me to understand. But that toolkit does have suggestions of how to write about specific things about a patient in a way that doesn't is not as much of a bias for the next person reading it. It writes it in a way that's less stigmatizing.
Dr. Martinez, I just want to make sure if that didn't get to the heart of it, feel free to raise your hand or unmute, and we'll definitely clarify the question.
Answer my question. Thank you.
Oh, perfect. Actually, as a corollary to that, Dr. Capron asked, are there guidelines or standards out there to help create appropriate confidential access for teens?
I can take that one. So the short answer is not really. Epic is infamous for not having a great solution for adolescent confidentiality. The state laws and the federal laws between 21st Century Cures Act and what teens have confidentiality to in the Washington state, there's a lot of conflicting recommendations and guidelines on what we should be hiding, what we should be sharing. So what Seattle Children's has, really our approach is following the state laws on what teens have rights for confidentiality to. So things that they care that they can consent to without their guardian. So things like reproductive health, for example, and mental health, for example. So those are the things that we are sort of categorizing, as confidential and protecting those from being released to MyChart. But I would say in general, there isn't really great guidelines or standards out there, which is why this is such a tough topic. And how we are approaching it is really starting with the federal and the state regulations, and then creating what we can with the technology. And I'm happy to touch base with you, Dr. Capron, offline if you want to sort of have an idea of how we are approaching this at Seattle Children's.
Yeah, that is a question that is near and dear to my heart. And I think that as we, even in our organization, had switched to Epic, one thing that we had noticed is that we were telling a lot of adolescents to join MyChart, but then if I printed the visit summary versus the front desk printed the summary, actually the link was going to the parent to join the MyChart, right? And so we have that conversation. We think about the unintended consequences of like handing somebody a piece of paper and be like, do this, right? But where is that information going literally when you print it in clinic? So a really great question.
And Peter.
Sorry.
Oh, go ahead, Clara.
No, I was going to say from a adolescent, the other thing that the spirit of our project that we're approaching here is also, we know that parents and guardians are accessing the teens MyChart. They're signing in as a teen, right? And most of them don't want to. They just feel like they can't access information otherwise without signing in as a teenager. And so what the other approach that we're doing is we're really creating a my chart level of access for our guardians to disincentivize them from doing that, so that teens can feel that their account is their account and no one is going into their account, so that if they are sending a message to their provider about, hey, how do I get on birth control pills, they can feel safe that that message isn't being read by anybody else. Sorry, I didn't mean to interrupt.
No, that's okay. I just wanted to jump up to Dr. Abel. She had something in the chat that I think we'd skipped over a little bit.
No, she's the next one. I was actually gonna read. Do you see the question? Because if you
I do.
Okay,
Yeah.
cool.
So, and this is a challenging one. So how do we protect against bias from third-party access to medical records and in images and external info? And as I read that, I was thinking, you're right. We have all this information that's coming in and our information that's going out. And so how do we, if there is language that's biasing to us, how do we protect from that? Because we can't change that information. It's been written, it's coming into our EHR from a third party. The amount, it is a really big challenge. And I don't know that we have a way to do that. We need to be mindful as we read the charts as well, because we can't fully 100% protect against bias that someone else might put into the chart. And so we have to be careful not to be taken by that stigmatizing language that might come into the chart from an external source or from an internal source. And then you also talked about AI and information that's in the chart, how that can be incorporated by those third-party tools that are added on to the electronic health record, how to counsel patients about what to put in there versus not. This becomes a really complex question, because you're right, as I counsel my patients about internet use, I always tell them, what goes on the internet stays on the internet. So don't put anything out there that you wouldn't want to be revealed 20, 30 years down the road when you're running for president or whatever happens. So I think the same thing needs to be, I don't know that it's the exact same though, in the electronic health record. Yes, information is kept for longer, but that information is also secured differently than on the internet. And as we incorporate AI and third-party applications into the EHR, we need to be very careful. And this is our job as CMIOs, to make sure that that information has a barrier, so that information that's taken in is not then consumed and used outside of the EHR. That information is kept confidential, including pictures and images that are uploaded earlier in life. I'm not sure if that completely answers your question, but I wanted to make sure to touch on that.
No, it's why I actually left it closer to the end. It's a big can of worms. And the other thing that I also think about is, the way you were talking earlier about note bloat and the way that we pull in information. People love to pull in like prior notes, and they don't. Sometimes, when you're reading over a note, at least as a primary care physician, you might not read literally every single detail of the HPI, but you're going to read like the assessment and plan. And depending on what you keep pulling in and where your eyes go, you might see different information every time. And it's really something that we need to continue to be cognizant of, especially as AI gets introduced in some of our workflows, someday in the future. Another question that came through: how do we change the 24/7 clinic job, i.e. the never-ending clinic day, that MyChart and the In Basket has created? How do we incorporate electronic communications between providers and patients into actual work hours?
Okay, I can kick us off on that. Aaron and I debated quite a bit on whether we should include this into the presentation. There are so many ways that people are trying to address this, because now as I mentioned, post-pandemic, we now realize that this is a 24/7 job. People are emailing us 24/7, whether they're expecting an answer back right away. And so one, of course, using AI, a lot of different vendors are now using AI to draft a MyChart response for the physician and the provider to say, yes, I agree with this draft, to send it back to the patient. That still takes time. It's not super accurate. The AI still hallucinates. So it's kind of an imperfect solution. There are other ways, other organizations, what they're doing is incorporating what's called a care team approach. So really empowering the MAs and the nurses in the clinic to help do the sort of first pass in these messages so that the providers are getting the provider level sort of questions, so empowering everybody to work at the top of their license. And then, really at Seattle Children's, at least what we're doing, one of the pilot is looking at messages that need to be converted into a visit. So into either a telehealth visit or an in-person visit, and really trying to do that proactively so that it is incorporated into the actual work hour. And then lastly, this is what we debated on whether we include this or not, is that there's some places like UCSF, and actually you probably read this on New York Times too, that are really charging for MyChart messages, even though it's not part of your actual work hours. The hope is that you can get compensated for it as a provider. It's really a very divisive topic. And when it's actually put into use, I think at UCSF, who's the first to come out to do this publicly, they're really only charging about 1% of their MyChart messages. And of those, the 1%, there's not a whole lot of inequities in the earlier studies that they've done, but it's not a whole lot, and it does create a lot of patient discomfort when it comes to sending their providers messages. And so they have seen an overall reduction in their MyChart messages over time since they've publicly announced that they're going to charge for MyChart messages. But it's, like I said, really providers compensation is less than 1%. So Aaron, anything to add?
I'll just add quickly, I know we're out of time, but thinking about this move from fee for service, where we're getting a fee for each patient that we see, to more of a value-based care, I'm hopeful that that will include some sort of a recognition of that work that's being translated away from the visit to these MyChart messages, asynchronous visits in a sense. But I think you also get to the heart of the other question, which is, in the past, some of us would stay after work and do all of our charts, and we're more meticulous, and that turned into almost a 24/7 job. But now we have access to it all day because it's on our smartphone, it's on our computers. And so we have to be cognizant of our own limitations, make sure that we're communicating to our patients, that our portals have that language that says, if this is an emergency, call 911. Otherwise, the expectation is your provider is going to respond, or their care team will respond the next day or within a certain amount of time. And we have to be sure that we are turning ourselves, our minds off of that and getting our own fulfillment outside of work. Otherwise, we'll burn ourselves out. And I think as pediatricians, we are particularly vulnerable to this because we want to be there for our patients. And it's hard for us to turn that caring off. Not that we're not caring, but that ability to care for the patient all day long. We want to be there for them. So that was just what I wanted to end with. But thank you for the opportunity to be here.
Well, I'm so glad we ended up with that question, because I think when we have this conversation about EHR design equity, it is about caring for our patients and also caring for ourselves so that we're able to do this for a really long time. And as the landscape of healthcare changes, certainly the level of difficulty has become much higher than even 5 years ago. And so we thank Dr. Grigg and Dr. Lin so much for this incredible presentation. And personally, I can't thank you enough. This has been really exciting to learn more about. For those that are still here, we will let you go in a minute. I just wanted to say that we do have a short survey that we're asking people to take to share their thoughts related to the webinar. And our next Equitable Care webinar, which the link was dropped in the chat, will be on December 6th on environmental justice. And so we hope that people will join us for that talk. But at this point, it is 8:01, and we hope that you guys have a great morning. We will see you in December. Take care.
Thank you.
Thank you.